I want to introduce Professor Stefano Partelli, who is the warrant of the Journal Club, and I'm very happy that he made it this evening. So tonight we're going to talk about psychedelics, but before talking about psychedelics, I would like to take you on a little survey of the history of psychopharmacology and leading up to a very important piece of news that came up about a month ago. And taking this little survey, I think, will help us appreciate better why this news is important, why it's good news. I will end up giving you my opinions on the critical aspects of psychopharmacology of today, and what I think needs to change. I want to start by saying that I am not at all an expert in psychiatry like Anna Marchesi, who will follow us, so please correct me if I'm wrong and feel free to intervene. I mostly know about pharmacology, and I'm hoping with this presentation to make you to give a clear idea of what is going on in psychopharmacology. So let's start actually with the history and how everything got started. Surprisingly, our story about hallucinations starts with a surgeon. In fact, in 1950, the drug chlorpromazine was synthesized in an attempt to make an antihistamine. And Henri Laborie, who was a surgeon working in France, in 1952 used it as a part of an anesthetic cocktail, but described a strange reaction in the patients who were administered chlorpromazine. In fact, he described them as detached and apathetic. We now today know that chlorpromazine began the class known as typical antipsychotics or first-generation antipsychotics, which comprises others such as tioridazine, trifluoperazine, flufenazine, and the famous haloperidol. And it was very important because chlorpromazine, as you can see, together with these other drugs, is mainly a D2 antagonist, so an antagonist of the receptor of dopamine. And in the 50s, the use of this drug, which was given to psychotic patients and severely agitated patients, brought about the idea that dopamine was at the center of the hallucinations in schizophrenia. So together with the fact that some other drugs like cocaine and amphetamines, which increase the availability of dopamine, and the fact that chlorpromazine, which was an antagonist of the dopamine receptor, stopped hallucinations, the dopamine hypothesis developed and formed early on, which states that dopamine is at the center of the pathophysiology of schizophrenia. In particular, a hyperdopaminergic tone in the CNS is responsible for the hallucinations. Just as a brief recap, the dopamine pathways that are in the brain are four: mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular. The main ones we're interested in are the first two, so the mesocortical and the mesolimbic. They go from the ventral tegmental area in the midbrain to the cortex and to the limbic system. And the theory is that these two pathways were hyperactivated and caused hallucinations in schizophrenic patients. The nigrostriatal and tuberoinfundibular pathways are mainly involved in the side effects of this drug, but I think this is out of the scope of the presentation, so we will not talk about them. However, as this hyperdopaminergic thesis developed, it was not able to explain everything quite well. In fact, as we have talked actually with Anna in a previous meeting of the Journal Club, a major feature of schizophrenia are cognitive symptoms and negative symptoms. So the idea that a hyperdopaminergic tone was responsible for these symptoms did not fit very well. And so two other sort of ideas formed, which tried to explain how dopamine fit into this model, which were that there was a reduced dopaminergic transmission in the dorsolateral prefrontal cortex, so the cognitive center, the superior function center of the brain, and a reduced inhibition over the limbic pathways, which resulted in the hallucinations. At the same time, however, as we will see later briefly, in the 50s, 60s, and 70s, psychedelics were beginning to become more popular. And the observation that psychedelics, drugs that are similar to serotonin, produce hallucinations, and the synthesis of another very important drug, which is clozapine, which is a serotonin receptor antagonist, brought about the so-called serotonin hypothesis, which now stands parallel to the dopamine hypothesis, in which serotonin is the main responsible of the hallucinations in the schizophrenic patients. So the LSD and the clozapine discovery actually added to the explanations of the pathophysiology of schizophrenia. And so dopamine and serotonin now are equally held into consideration. As I said, clozapine was the first drug to be discovered, and it is the main family member of the second generation antipsychotics, the atypical antipsychotics, which differently from the typical ones, as we saw earlier, that target the dopamine receptor, they target the 5-HT2A receptor. So the serotonin receptor 2A. These are olanzapine, quetiapine, all very famous drugs. There are two exceptions. Actually, clozapine was later discovered to be very specific for the serotonin receptors 6 and 7, although we don't know their function. And it is possibly the reason why it is so effective in schizophrenia and why it has so many side effects. And aripiprazole, which is also a very effective drug in schizophrenia, is actually mainly a D2 partial agonist. So it is able to increase dopamine where it is not enough, and decrease dopamine where it's too much. Just as a brief review of serotonin, serotonin has many different roles in the brain and in the body. Here you can see the serotonin receptors by importance and by, let's say, therapeutic relevance. So as we said, the 5-HT2A receptors /C are excitatory. They mediate the majority of serotonin actions. The 5-HT1D and B are actually involved in the meningeal circulation, and drugs that target these receptors are triptans and sumatriptans. Many of us know them because they are used to treat migraine. The 5-HT3 receptor is found in the chemoreceptor trigger zone, in the adipostrum and the NTS, and is involved in emesis, and some drugs target that, like metoclopramide. The 5-HT1 receptor broadly regulates mood, anxiety, and thermoregulation. And finally, as I briefly mentioned earlier, the 4, 5, 6, and 7 receptors are actually unknown in their function. And so it's still a mystery as to why clozapine, that is very selective for the 6 and 7 receptor, is actually so effective. So let's come to us. Let's come to psychedelics. Here I listed the 4 main psychedelics that we're going to talk about, which are psilocybin, mescaline, DMT, and LSD. Psilocybin is the active ingredient in the so-called funghetti hallucinogeni, or mushrooms, and it's part of the tryptamine family. Mescaline is found in peyote, which is a cactus in Mexico, and is part of the phenylethylamines. DMT, or N,N-dimethyltryptamine, is found in ayahuasca. That is a vine found in the Amazon rainforests. And LSD is a very famous synthetic psychedelic drug that is a sort of symbol of the 60s and symbol of the logo of the presentation as we started it. Can anybody guess how these psychedelics work, given what we have seen so far? No answer is a wrong answer. I'm sure that you can give it a try.
Maybe they act like serotonin.
Exactly. This is the right answer, correct. So they have a structure that is very similar to serotonin. So the 5-hydroxytryptophan molecule. And so they are serotoninergic, and they have most of their selectivity on 5-HT2A receptors, which, as you remember, is the receptor of the antipsychotic molecules. So they are considered psychostimulants. As we said, these receptors are excitatory. And two other important pharmacological aspects are that they induce short-term tolerance, which means that if you take an hallucinogen shortly after a first administration, it will have less of an effect. And finally, that they do not have withdrawal symptoms. They are not addictive. So what are the effects of hallucinogens? There are four main categories. The first one and the most famous one is probably the distortion of shape and movement. And so I decided to put a little dragon there because, as the saying goes, you see dragons. You have honing of special senses, such as taste, hearing, eyesight, and smell. You have an alteration of time perception, and you have synesthesias, which is a perceiving two senses as bound together, even though they're not in normal perception. You can also have a bad trip, of course, which mainly involves anxiety, nightmares, and panic. This is actually quite common depending on the setting in which the drugs are taken. But they're quite short in terms of their duration. However, in long-term and chronic users of hallucinogens, you have two complications which are actually quite severe. The first one is HPPD, which stands for hallucinogen-induced perception disorder, in which the patient experiences sort of flashbacks, they're called, in which they relive part of their hallucination, which can be quite terrifying. And then you can have frank schizophrenia, so the onset of a full-on psychosis. These are quite rare. It's difficult to estimate their prevalence because self-reporting of illegal drug use is quite complicated and quite not very statistically valuable, but it is estimated that HPPD stands at around 1 in 50,000 or something like that. Some say even more. So they're very, very rare. And remember, these are long-term side effects, so not in single-time users. But let's see the psychedelics used in history, because that is very important for how they're used today. So as we said, peyote and ayahuasca are two important ones, which are naturally derived. Peyote was used in Mexico, and there are carbon dates of peyote buttons being used up to 4,000 years ago. They have used peyote in ceremonies for, again, many, many years. And the same goes for ayahuasca, which is DMT, which was used in rituals, which was used in ailment healing, and is described as providing an intense emotional experience, which usually ended up with vomiting. More recently, instead, we have the psychedelia era, so the 60s, the 50s, the 60s, and the 70s, in which a proper subculture developed around the use of psychedelics, which had its epicenter in San Francisco, involved musicians and artists and writers, and had many famous proponents, philosophers and thinkers like Alan Watts and Aldous Huxley, which personally used psychedelics and advocated for their use as a way to expand your consciousness and get into contact with a divine reality. The users of psychedelics were funnily called psychonauts. So the idea of this, the trip that the psychedelic induced of something that took you in outer space, right? In some cases in inner space as a sort of inner self journey and inner self discovery, but also in terms of a newly found creativity and discovery of the reality as we perceive it. So let's come to our news. The news article which pushed me to talk about psychedelics in the first place, and this is a strip from The Economist, where the news is given that in Oregon, psilocybin was approved for the treatment of several psychiatric diseases like depression. This was about a month ago, and Oregon states that they should have treatment centers opening in the spring of 2023. So they're sorting their stuff. Let's say it this way. Let's put it this way. And this newspaper article, which obviously is quite sort of non-scientific, let's put it this way, advocates or discusses the possibility of psychedelics being more and more available. In many countries around the world, psychedelics are become less important and prioritary to the police. It seems that they are not viewed as so bad for society, let's put it this way. And the idea that psychedelics can be used in psychiatry is actually an idea that is sort of resurrecting in the last 10 years. Nutt and Carrot Harris, which have done a review of the current status of psychedelics in psychiatry, state that in the past decade, this interest in psychedelic was born out of two main reasons. The first one was a paper published by Griffiths and his colleagues, in which they described that a single dose of psilocybin, which is the most commonly used psychedelic in psychiatry, was able to provide positive, long-lasting changes in the mood of healthy people, which is incredible. Like the idea that a drug is not meant for a patient who has a disorder, like major depression, but can also be used by healthy people. And this was sort of accompanied by neuroimaging studies, which showed that there were profound changes in the default mode network of the CNS, which is actually similar to what is seen with antidepressants like serotonin reuptake inhibitors. So these two drivers are pushing psychedelic research forward. So psychedelics can be used for and are being used for several psychiatric disorders, the majority of which are internalizing disorders. So depression, anxiety, eating disorders. And this is part of the reason why, or the proposed way they work. So internalizing disorders are all disorders which feature a process of rumination. So a process of repetitive thoughts about, for example, one's failure or one's inadequacy or one's self-image, and are typically disorders that force you to keep your emotions inside and not express them. Externalizing disorders could be acute aggression, for example, which is not approached with for treatment with psychedelics. And so the idea of how the hypothesis of how these psychedelics work is that they disrupt the circuit of rumination, so interrupting this automated circuit of negative thinking, and allow for insight to occur during the hallucination. So the experience of a psychological journey which illuminates some kind of conflict that one has in his profound psychology and emotional intelligence, and with the help of psychotherapy, allow to recalibrate the associations which provide distress. So, to give you an idea of how these depression trials work, since depression is the major sort of target that is being explored for psychedelics, they are usually divided into 4 phases. The first one is the assessment, in which mental and physical eligibility are checked. And you have some important exclusion criteria, as you can imagine, such as personal or family history of psychosis or bipolar disorder, because you would never want to exacerbate an existing psychotic disorder. Also, uncontrolled hypertension can be a contraindication because they might increase blood pressure. And finally, you must interrupt or reduce serotonin antagonists and other serotonergic drugs, which are serotonergic drugs are very common in depression, like serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors. The next phase is preparation, in which the day before the experience, the patient has a session with a therapist, who is often referred to as guide, as a term borrowed from the shaman world, in which the patient is told that the psychedelic experience is a psychological journey, and the overview of the dynamics of this experience are given. So how to get the best of it, what one can expect. And finally, what challenges may arise and how to confront them. As we mentioned earlier, a bad trip, let's put it this way, is a possibility, and so one must be warned about it. Finally, the experience involves an administration of psilocybin, which is 25 milligrams. The session lasts about 4 to 5 hours. And the patient, this is kind of interesting in my opinion, the patient is offered eye shades and earphones. Eye shades because even though the patient experiences the hallucination more strongly than reality in the majority of cases, apparently eye shades allowed the patient to concentrate inward and concentrate on the psychological journey indeed. And earphones because the patient is encouraged to prepare a playlist, a music compilation, and they have seen apparently that listening to music enhances the effect of the treatment and the experience as a whole. Verbal engagement during the hallucination is not expected. So the guide is not expected to talk to the patient. The patient usually does not want to talk to the guide either because he is concentrated in the journey. But prior to consent, the guide can hold the patient's hand to remind them that they are being taken care of and that they're being taken care of and that they're safe. Finally, and this is the most important phase, the following day you have the psychotherapy session with a guide in which you make sense of your experience, of the experience that you had. This means analyzing issues that emerged and insights to integrate. So often the patient is not able to make sense of something that he saw in the hallucination, something that he felt. And the therapist is a trained therapist that helps him into integrating the insights. So in making the insight or the experience part of his conscious and rational life in order, again, to better his quality of life and to untie some knots, let's put it this way. Additionally, you might add some psychotherapy sessions, which are ideally standardized and talk-based, but this is optional. So why is this good news? I mean, why did I decide to talk about this? Number one, it's an alternative therapy. As we know, depression is an increasingly common disorder, or at least an increasingly commonly diagnosed disorder, especially in the Western world. And there are not so many treatment options, and we will talk about this later. So anything that is alternative to the standard of care is welcome, especially for treatment-resistant depression, which is the main type of depression that psychedelics are being used for right now. Number two, it is safe. As we said, the incidence of severe side effects is very, very low. And so, yeah, it does not have other organic side effects. It only might induce anxiety or a bad trip, but that's mainly it. The third reason that it's fast. And this is actually very important because if you think about it, SSRIs and SNRIs, which are probably the most commonly prescribed drugs for depression, are actually very, very slow in their onset of action. They usually take a month or up to 2 months possibly because of the specifics of how they work, which we can delve into later better if you're interested. So the idea that 2 doses of psilocybin in 2 sessions in the span of 2 weeks can possibly solve long-term a chronic and severe and debilitating disease as depression is fantastic. And the final reason is that it's cheap, right? Because the majority of these drugs are phytoextracts, so plant-derived. They are very common. They can be grown. They can be extracted. It's only 2 doses. So these are 4 very important features of psychedelics that actually are good features for any kind of drug, but especially, in psychopharmacology. However, there are a few methodological issues that I wanted to discuss about. One is very important. I was wondering while I was reading this article, like, how is it possible to control something like a psychedelic, right? I mean, in randomized control trials, you need to have a control arm in which the subjects are not administered the therapy arm drug, right? But it's obvious if you take a psychedelic, you realize you're taking a psychedelic because you start having hallucinations. And if you don't take one, you also realize you don't take one. And you have to consider that the majority of control arms are administered drugs like escitalopram, which are SSRIs, which, as I said, take 1 month, 2 months to work, don't have any immediate effect. And so the problem of unmasking or deblinding is very important, because the patient that enters such a trial might have expectancy of the results, expectancy of the benefits of this drug, and might perceive a benefit where actually the drug was not responsible for it. And the second thing is the therapeutic alliance, which is, again, very important and a complicating factor in many psychiatric trials, meaning that depending on the rapport that is built between the patient and the therapist, the perception of the benefit of the treatment might change. And also the standards of the psychotherapy. This is something that is discussed quite often in the psychology world as a problem in the sense that different approaches are difficult to be standardized, and that's it. So this is we're approaching the end of my presentation, and we talked about the methodological issues of these trials, but I think that the importance of this news about the approval of psilocybin in Oregon falls into a larger context, which is that of the critical points and the criticism of psychopharmacology. For one thing, consider that Prozac was approved by the FDA in 1987. And after that, nobody looked for the next Prozac. There is a market stasis for psychiatric drugs. This is for two main reasons. One of them is actually mostly one reason, which is that the market for psychopharmaceuticals is very risky. It is controversial and it is very expensive. Trials are expensive, they're difficult. And at the same time, it's not a safe investment that investors want to take. And so slowly in the last 10 years, pharma companies have pulled out of neuroscience and pulled out of neuropharmacology and psychopharmacology up to 70%. So there was a 70% reduction in investment in this field, just to give you an idea. And this is why after Prozac, there wasn't another revolutionary drug. The second one is imprecision. We know a lot about neuroscience and psychopharmacology, but definitely not enough. Something that they always tell us is that at a severely psychotic and treatment-resistant schizophrenic, you end up giving antidepressants. And that a severely depressed patient who is treatment-resistant, you end up giving antipsychotics. So the pathways we talked in the beginning about, dopamine, serotonin, and other pathways such as noradrenaline, and so on and so forth, all intertwine and make it very difficult to understand. So this adds to the complexity and the reason why research has sort of stalled. And finally, there are major critics of the psychopharmacology of today, such as Joanna Moncrief, who is a British psychiatrist. And she has just put here two of her theses, which I think are quite poignant. And one is the idea that drugs, as we saw actually, are sort of magic bullets. So they were discovered by chance. They were given to patients randomly and seen, and they just studied in which patient these drugs produced an effect. So as we saw, chlorpromazine is a perfect example of it. It was discovered, it was synthesized as an antihistamine, used as an analgesic, and finally they realized that it was potentially useful in psychotic patients. And so the idea that the development of psychiatric drugs is random is definitely a weak point, a structural weak point of the psychopharmacology field. And the second one is the drug-centered model versus the disease-centered model. So Dr. Moncrief contends that the way we use drugs, psychiatric drugs today, is by having the drug and using it on all the patients with psychiatric disorders and approving it for those patients in which that drug has an effect. So the idea is that the psychiatric drug is a psychotropic drug in any person, but in some people with disorders, the drug helps. And she says that this is definitely a wrong way to go about giving drugs to patients. She'd rather, as we all would rather, understand the disease first and then find a drug which might help. An example of this was L-DOPA. They saw that in Parkinsonian patients, there was a deficiency of dopamine. L-DOPA was synthesized. Parkinson's had a first line of treatment. So it is possible, but again, it is very difficult. Psychopharmacology has a very complicated history, and these are my last two slides. This is a picture of a very famous surgeon, Freeman, who performed lobotomies up to the 60s and 70s as a treatment for uncurable mental ailments. He was seen as a sort of god in the medical world. He operated, as you can see, without gloves, without a mask, with an audience. And he invented this, frankly, barbaric method of modifying an ice pick, a pick used to cutting ice, to insert in the orbital cavity of patients and basically destroying the frontal lobe. This is called transorbital lobotomy. And the Nobel Prize was awarded for lobotomy quite recently. The physician who invented the lobotomy, which was a Portuguese physician, actually won the Nobel Prize for it. And it's interesting how lobotomy was an accepted treatment up to the 60s and 70s. In fact, JFK's sister got a lobotomy. If you think that's crazy, he was one of the most influential and rich people in the US, and he made his sister get a lobotomy operation. So this is to give you an idea of how lobotomy was so very important, and in a matter of few years, it was described as immoral and barbaric, and it was shut down, and now it is illegal in the majority of the world. But there are still many practices which are very imprecise, let's put it this way, as lobotomy, so just destroying stuff, like electroconvulsive therapy, which in the US and Canada is very common, or insulin shock therapy, which are just ways of resetting the brain in a very imprecise and very dirty way, let's put it this way, not a very selective way. So psychopharmacology definitely has a complicated past and must, because of its complications, carry on these burdens even today. However, there is an exciting future. So not everything is doomed. This is Spravato, which is a drug that the FDA approved, I think, 2 years ago, which is actually derived from ketamine. And in fact, in these past few years, there are many trials that are revolving around the use of ketamine. As you all know, ketamine is a local anesthetic. But as of recent, they discovered that it had strong antidepressant properties. In particular, it's important because as psilocybin, in a sort of sense, it is short-acting and fast-acting, let's put it this way. So patients who are very suicidal, for example, depressed patients who are very suicidal and treatment resistant, if given ketamine, immediately feel better. Now, it's still early stage, right? So we need to assess whether ketamine can be taken long-term, what are the side effects, the addiction capability of these doses. So still, it's kind of murky territory. But this is an actual spray, Spravato, which was approved. And you take it, you spray it in your nose twice a week, and it hopefully makes you feel better. So these are there are five take-home messages that take-home ideas that I want you to get out of this. The first one is, again, D2 receptors, 5-HT2A receptors are key actors in schizophrenia. Psychedelics act by mimicking serotonin, so are serotoninergic drugs and act on the 5-HT2A receptor. Serotonin is a stimulant, actually drugs that mimic serotonin are psychostimulants, such as psychedelics. Psychopharmacology is a complicated field with many controversies, many technical difficulties, and definitely in need of new drugs. And yeah, new research is needed and new investments are needed in this field if we want to make the lives of treatment-resistant patients slightly better by giving them alternatives. Thank you for your attention. You can make your own questions. Please be kind, because I'm not a psychiatrist. So yeah, thank you.
Thank you, Pietro.
Oops.
I have a question, P. By the way, great work. So, effectiveness of psilocybin, what does the data say?
It really depends on the trial. It's not perfect, especially because placebo is still has still to be calculated. But from the trials I read somewhere about a 40% in perceived improvement in severely depressed patients. But again, it is very, I mean, solid statistics are still needed regarding this. I think Oregon is a sort of path opener. It's possibly a little early, but the FDA called psilocybin as a breakthrough therapy. They called it a breakthrough therapy, which means that they will try to facilitate the approval of psilocybin for depression. I mean, again, it's better to be safe than sorry. So I think that, you know, you need to calculate safety, the safety profile and the placebo effect kind of better. But again, I mean, I think that even if it doesn't have an incredible effectiveness, it's important to have an alternative to existing drugs, and that's the good news. Mm-hmm. Because you finish the drugs you have very quickly. So yeah, psilocybin is good news.
And what about the efficacy of the ketamine inhalant on the depression?
I have not analyzed it into depth, but it is very, very effective. Like, I mean, I can definitely check up on that and let you know. But it's incredibly effective, and they're going to approve it quite quickly. At least in the short term, it's very effective.
The only thing is that, as like clozapine, it can only be given to patients that are resistant to the other treatment.
Yeah, like psilocybin. Yeah.
Exactly. So you cannot give it like to everyone. Plus, like, it has to be given in the hospital. Like, you cannot give the spray to the patient and say, "Oh, take it home." You have to take it in the hospital. At least, I don't know in the US, because there has already been approved by the FDA. In Italy and in Europe, it has not for now. So in Italy, like in Turro, we do it. Like, there are patients on esketamine, but they are within clinical trials and can only take it in the hospital.
And this is because of addictive potential?
Yes, but mainly on the side effects on the short term, because you can faint, so patients have to be controlled. Like, when they are administered esketamine, then they have to stay in the hospital for 2 hours and like being followed up by doctors and nurses due to these side effects. Like, we had one patient that fell off the stairs after, so we have to be careful. But otherwise, like you said, it's a big advantage, because the major problem antidepressant, that, by the way, compared to antipsychotics, work much better in depression compared like to antipsychotics in schizophrenia. But the problem is their long-term effect. Like they take a very long time to actually have like
you cracked a little
the
bit.
psychedelic. No.
I understand. Another
Can you hear me now?
Yeah, I can hear you.
Listen.
Another interesting thing is that serotonin.
Perfect. I'm done.
Serotonin actually, pharmacologically speaking, is depressogenic and anxiogenic, and this is quite confusing. Possibly, it's the reason why antidepressants in the first few weeks have a high risk of suicidal behavior. But if serotonin is given purely, its action on its receptors is depressive. So the proposed mechanism by which serotonin reuptake inhibitors, which increase the availability of serotonin at the synapse, treat depression is that over a long period of time, the receptors for serotonin are downregulated because of the increased amount of serotonin. And so the whole system is the whole network, as we talked about earlier, is defaulted, and you feel serotonin more than you felt it before. Let's put it this way. So again, it's a very confusing world. Yeah. Do we have any other questions?
Pietro, may I ask you? I'm sorry.
Please.
Okay. Congratulations. Very interesting talk. Maybe I missed something, but I wonder if these are ongoing trials, or we have just already some results regarding comparison of psychedelics and, let's say, traditional drugs for depression, for example?
Yeah. I mean, as I said, they are mainly drugs that are used in treatment-resistant depression. So you have a patient at the last line of therapy who is not getting better. So I guess that non-inferiority trials or comparison trials with other drugs are not the priority at the moment, because psychedelics would be considered the last line. But I know for a fact that controls are, for example, serotonin reuptake inhibitors. So I guess that some sort of comparison, at least for placebo purposes, is being made. But I'm sure that if it proves to be safe, comparisons for first or second line treatment might actually be made more sort of more solid and with a larger population size. But yeah, I don't know specifically. I guess there might be active trials that compare the two, even for earlier lines of treatment.
Okay, thank you. And is it a single shot therapy, just one?
Some do one dose, some do two. But yeah, the average is two. The most common dosage is 2 over the course of 2 weeks. So one at the beginning of the first week, the second at the beginning of the second. I'm not sure why. Again, these are all things that must be calculated. Like they should compare 2 doses versus 1 dose, or 4 doses versus 2. These are all things that are ongoing, right? But yeah, it's 2 for now.
Thank you.
Yeah, of course. Okay, so if there are no more questions, I think we can call it a day. I hope you're interested. If you want the slide pack, I can send it to you. You can send me an email and reach us on Instagram. Yeah, thank you very much for your attention. I'll see you next Wednesday with a presentation on von Hippel-Lindau syndrome.
Thank you, Pietro. Thank you.
Thank you. Have a good evening.
Thank you. Bye.
Thank you.